Welcome to CTO session. My name is Neiri, chairman, and another chairman is Dr. Okamura. Now we'll meet Kenya Nasu. Hi, can you hear me?
Hi, I can hear you. Good afternoon, everyone. So thank you very much for invitation in the complex PCI this year that the live demonstration site. So can I introduce my case?
Yes.
Yes, our case is a 70s female, is a target region at LAD. So she had the angina pectoris post myocardial infarction. He received the drug eating stent in a right coronary artery in this June and October. She had the hypertension and this limited as a coronary risk factors. So ejection fraction is okay, and EGFR the 58. So this case is the syntax score the 21.5 and the JCTO score 1. So I will show the initial angiogram. So the Gナビに戻ってください。Gナビに。So this is a controlled angiogram. So you can see it already has a CDO with a tapered proximal cap. Next please. This is a cranial view. Next please. So cranial view, we can see that some stumps, the tapered stumps is there. So next please. This is a right coronary artery. So you can see that some separate corners is supplied the collateral channel to the distal landing zone. So next page. And so in terms of the collateral channels, mainly the artery branch and the conus branch. And also we can see the some connection via distal PD branch to septal. Okay, next please. Okay. So the CT 戻ってください。So I checked the CT yesterday. So CT angiogram showed that you can see the very big calcium from the orifice of the LAD to the proximal cap of the DCDO, but the CT length is very, very short. And also in terms of the morphology of the distal landing zone, we can see some spot calcification, but no severe calcified region around the distal target point. Okay?
Okay, yeah, we understand.
Okay. So I can show you today's angiogram. Of course, in this kind of the situation, usually we selected the conus, we try to select the conus branch to do the chip injection, to super selective injection, to visualize the distal landing zone. But for this case, is the engagement of the insertion of the wire to the spotted conus branch is very difficult. So finally I gave up to inserting the wire to the conus branch. Next please. Next please. Well, next. So this is a chip injection from the RL coda view. So from the antegrade flow that we cannot see. So next please. So we should check the bilateral shot with the chip injection from the antegrade side. So the injection is not perfect, but we can see the distal landing zone like this. So you can see it's a very short region is there. So I also checked the RL coda view. Next please. This RL coda view, we can see also very short CDO segment at the middle of the LED, like this. So this is the current situation.
Okay, so yeah, we will ask the commentators how to do it. Okay, so we have your commentator. So Dr. Hirohata, how do you think? Strategy.
I'm Dr. Hirohata from Japan. Well, according to this angiogram, the length of the CTO seems to be very short and seem to be relatively straight region. So I'd like to start with the antegrade approach first. But seem to be the region seem to be very stiff, so choose a relatively hard wire.
Okay.
じゃああれをこ
So
うだ
yeah.
として
Okay. So please.
I'm
Hold on,
Jungo
Ishii.
from Bucheon, Korea. So, yeah, as you look at see the retrograde approach is possible, but maybe the septal collateral connection is not seems to not good. So, but however, we can use the epicardial collateral or alveolar brain collateral. But however, that is so dangerous. So, I also agree with the antegrade approach because in the city it's a severe calcification exists,
戻っ
but
て
yeah. However, we can see the not tapered, so we can first time we try to the antegrade approach first. Yeah.
So if the antegrade approach is failed, which strategy you will select next? Next strategy. Doctor Su. So yes, yes.
Yeah. So first we can try the anterior approach. Not it's impossible or also difficult. We can change the retrograde alveolar bench collateral. So
Okay.
そうなんだ
So Dr. Ishihara, your strategy?
Yes, thank you. So the visualization of the CTO exit is very important. So the Dr. Nasu try to get the separate cones, but so if we can get the separate cones, it's very supportive. But unfortunately, it is so difficult. So, but fortunately, so we can see the distal target not so clear, but so we can start from antegrade. And if the one antegrade wire migrated into subintimal space, at that time, of course, one option is parallel wire, and another option is IVUS guide re-entry or re-route. So this distal part have the bifurcation of the diagonal branch. So I try to do the parallel wire second, and if it failed, I do the IVUS guide wiring because retrograde route is now we can see the RV branch. It is if we have the possibility, but there is some tortuosity. So that parallel wire, and if impossible at that time, IVUS guide wiring. But so during IVUS guide, so we should be careful of the loose of the diagonal branch. It's my opinion.
So do you think about the retrograde approach because there are several options, OM branch to the maybe the LAD and also some septal channels to the LAD because this is a two bifurcation at the diagonal branch. So how do you think about the retrograde approach, Ishihara?
Yeah, so I'm sorry, I can't follow the septal channel possibility. So that if there is enough possibility, of course, it is also a very good option.
Okay, so Dr. Jim Berry, how do you think?
Yeah, I integrate the approach first, and then I think the direction of straight in the diagonal branch first, and I think this way easily go to the diagonal branch. But I think okay, already Nasu.
Oh yes,
Nasu
yes. You succeeded.
Overcome,
you have succeeded.
Overcome.
Yes, yes.
Yeah.
So we, Dr. Nasu, will you explain your strategy, your wire,
yes.
and also your method?
I fully agree with you. This is a very short segment region with a tapered type, and in a CT angiogram, it's not so calcified. So everybody agreed to start the antegrade first. So I started. So XTR の画像残ってない。I started from the XTR because the very tapered type of the proximal cap. So XTR is a little bit advanced, but I had a resistance in the distal landing zone. So I switched to the guy next one. I'm sorry, I could not explain, but because of the very time saving. So this is a guy next one. Guy next one is a very easy to go to the advanced distal landing zone. So I want to check the RO caudal. So this is the RO caudal view. And I selected the other iliocranial. This is a calculated perpendicular views with SPLX area, the calculation software to identify the perpendicular views from the Asahi intake. So that this view is, anyway, this view is okay. So that I will check the other perpendicular view. This is LEO 14 and the cranial 37. So you can see. I should check. I should select the LED itself. The another issue is from now we can check the IVUS and we try to select the diagonal branch, right?
Yes, yes. Yeah, that is a very important point. So if you perform the CTO intervention, the important point is you have to see the perpendicular direction. So the SPLX from the Asahi is a good software to check the perpendicular direction at each coronary artery like that. So Dr. Nasu did it, and then you will do the IVUS. So
バルーンで広げましょう。151そのあれサウザ。
So Dr. Nasu, you use the Carabel? So usually I wanted to use the Carcel compared to the Carabel. Is there some reason? Or your work was microcatheter?
Yes, depend on the case. I expected the region is not so hard. And also I prefer the bigger inner lumen microcatheter. So as you know, the Carabel is imaging quality is better than the Corsair.
Okay.
That's why I selected the Carabel today.
Okay.
But Carabel could not pass. So I used the 1.0 balloon.
Yes, yes.
ちょっと待って、リフレッシュ、リフレッシュ。ごめん。
In this case, the preservation of the diagonal branch is really important. So, just until the while, maybe sometimes it go to the relatively subintimal in the diagonal takeoff region. So, during this until the is there any specific technique or the knowledge to saving the diagonal branch?
Oh, no. Dr. Nasu, yes.
Yes, anyway, it's according to the wire course, but in my precision, I always use the not so hard type of the guide wire for the penetration of the distal cap. So because, the guy next 2, 3, 4 is very easy to go subintimal and also very easy to go shortcut the LED main vessel. So after shortcutting of the main vessel, is a selection of the diagonal is very difficult usually. But anyway, I'm not sure that my wire course today. Okay, down please.
Yes, the important point is a vessel course, the wired course. Because yes. So if you perform the guide wire to the more diagonal side, maybe the diagonal branch will be preserved. So the carina side is maybe the preferable to preserve the flow of the diagonal branch. Yeah, so this case is areocranial or the epicranial is a good view to see the root of the diagonal side guide wire passing to the LED. So
15.
you use
15? 15. No.
so is it which brand you used this balloon? This is
This is a Sauza from the Neichi.
Okay.
Neichi, Nipro.
Nipro. Yes.
Sauza is very nice balloon. Nowadays, we are available in Japan. Okay, again, 15.
May I know the size of the balloon? 1.52
No, this is only 1.0.
1.0.
I want to minimize the vessel damage in this situation because our next purpose is to preserve the orifice of the diagonal, right?
Okay.
So, but I want to close the Carabel now and change the wire and do the IVUS to see the wire course and the orifice of the diagonal.
Yes.
Okay?
Usually, early phase of the CT operator do a larger balloon compared to the Dr. Nasu's selection because we want to see the larger diameter, larger the opening of the CTO segment. So that makes it some difficulty in the rewiring to the diagonal branch sometimes. So this is really important for all the, especially for the early CTO intervention course.
Yes, I think so too. Okay. Hold on. Collection blue.
Is this Thermo IVUS or another company?
Yes, I'm using the thermal double R.
Yeah, Thermo IVUS is relatively profile is very low.
Yes.
Sometimes if we dilate using only 1 millimeter sized balloon, and then sometimes other company IVUS cannot cross the region. So we usually not before IVUS catheter. Before perform IVUS, we usually more than 1.2 balloon now.
I see.
Yes. So the tip size of the thermal IVUS is almost same as the Corsair. So after bougie of the Corsair, so you can advance the IVUS.
Exactly.
So I think that a 1 point balloon, millimeter balloon is enough to advance the IVUS maybe.
ちょっとワイヤー持ってくれる？ワイヤー持ってよ。ワイヤー持ってよ。さあ、どうかな。ちょっとタイトだけど、痛い。Okay, now we reached the distal landing zone. Support work, please. Probably this is diagonal, right?
Yeah, maybe it is connected.
I hope so. ちょっとマニュアルにして。Okay, this is almost orifice of the CTO. This is the how about? I hope this is okay.
Yeah, I think it's connected. Flow is wedged, but
Yes.
yes.
Well, anyway.
How do you think about Dr. Hirohata? He's an expert.
It's very difficult to see this diagnosis from this IVUS paths. Well, according to this IVUS flow of the diagonal branch is a little soft. It's kind of with that you can see some that blood flow or contrast is remaining in diagonal branch.
So diagonal branch is flow or dissect flow? Not dissection?
Well, I think it's no dissection because we dilated only 1.0 bar.
Maybe only the tight stenosis of the ostium of the
Yeah, I guess
diagonal
so,
branch.
yes.
And distal lengthen part seems have negative remodeling.
Yeah,
Yeah.
this type of looks okay.
Yeah.
The problem is the ostium of the diagonal branch.
Yeah, anyway, I will try to select the diagonal with DLC Sasuke. So if very difficult, I want to do the IVUS guided wiring. But sometimes we need to the hardwire to puncture the like a chip detection method to get the diagonal orifice with IVUS guidance. Right.
So, Dr. Nasu, is this a guide 7 French, 8 French?
This is just 7. Okay, so today I use a bilateral radial approach.
Oh.
So that's why this is a 7 French.
Oh. Maybe that's why you selected the Cannibal, because the Cannibal anti-rival 7 French is very enough
yes,
space.
はい、しようね。最初はしよう。で、1個前にして。1個前のアイバスの空打ち見して。流して止めては困る。よいしょ。なんかタイトステノーシスだけど嫌な感じだなこれ。
Yes, something is there.
なんかおかしいね。ちょっと最初の図見して。このダイアゴナルのバイハケーションが見えてる。もっと外に流れないとダメだね。
Dr. Okamura, we already confirmed the wire position in the two room, and then maybe diagonal branch space was connected. So in this situation, bigger volume may make a bigger space to wire to diagonal.
Yeah, if,
My
yeah,
strategy.
yes, so after the trying to the wiring like that, if difficult, yeah, one choice is opening or the rotor or some debulking. The next choice, but I think it's before the balloon dilatation or the some arrangement at this part. Maybe I will do directly to the IVUS guided wiring using the more stiffer wire. But he. Yes,
Ma,
yes,
I
yeah,
think
yeah,
it's
yeah, yeah,
okay.
you succeeded. Yes, yes,
Okay.
yes, yes, nice, yeah.
So, I want to check the IVUS again. ちょっとこれ拭いて、外。ちゃんと。いや、シャフトも拭いてください。
Dr. Nasu, may I know which wire in the diagonal approach?
This is just assume.
Just shown. Wow,
Yes.
thank you.
Shion has very good, nice trackability. So in this kind of situation, I always use the Shion as a first wire. よし。こらこらこら。はい。
So, after the IVUS checking, we will move to the next room. So, yeah,
Okay,
Dr.
okay,
Nasu, yeah,
okay.
Dr. Nasu just, yeah, so, yeah, so please do the IVUS.
Yes. 入れてちょうだい。ワイヤー持ってね。ちょっとこれお水くださいよ。よいしょ。よしっと。はい、どうぞ。これ秒一で引いてよ。はい。Yes. So you can see the diagonal wire from the 10 o'clock, right?
Yes, yes. We can
I
clearly
think
see
it's
it.
okay. Yes,
Okay.
it's okay. So I will dilate the region and put the standard to finish the case. Thank you very much.
Yeah, thank you, Dr. Nasu. Well, good presentation. Thank you so much. So we are moving to the next demo course.
Dr. Kim, can you hear me?
Yeah,
nice,
can you hear me?
nice
Yeah,
to
I
meet
can
you.
hear
We
Yeah.
hope for beautiful case. Please explain your case.
Okay, hello everyone. So this is the Yonsei classroom. So it's great honor to have a demonstration. Yes, and also I would like to appreciate SJ Bach and DW Bach. And we prepared RCA CTO case. So firstly, let me introduce our team. Is Professor Seung-Jun Lee, and my fellow is Dong-Won Kim. So Seung-Jun Lee, so could you tell us today's RCA CTO case?
Thank you. So, 74-year female underwent her PCI at LAD circumflex 2 months ago, and this is the second stage PCI targeting her distal RCA CTO lesion. Next slide. Previously, she had diabetes under medication and hypertension dyslipidemia. Particularly, her renal function is declined, corresponding to chronic kidney disease, stage 3. Her estimated GFR is around 40, and she is suffering the chest pain due to stable angina symptom, and her cardiac function is preserved. Next slide. So she is under optimal medication for ischemic heart disease. Next slide. So ECG shows no specific finding, and the echocardiography shows the preserved normal cardiac function. Next slide. This is the angiogram that 2 months ago. So as you can see, the medial LAD and the proximal circumflex region shows tight stenosis. Next. So we underwent DS implantation at the proximal medial LAD and the proximal circumflex. So after the installation of stent, you can see the grade 2 or 3 collateral flows are observed from the left coronary system to PD and PL branch both, but actually the conjunction point is not definite at the time, but due to her renal function, we planned to check it today. So next slide. This is the right side angiogram. As you can see, the tight stenosis is observed at the medial RCA, and the distal RCA CTO is observed, and no breaching collateral finding. Next. So we underwent CT analysis per our CTO-CT protocol, exactly matching to the procedural angiographic view. Next. So this is the comprehensive analysis. You can see that the lesion length is around at 33 millimeter, and the proximal cap looks the tapered tip, and I marked it the red circle. The calcification of the proximal cap is not so severe. However, at the distal cap, which is also sharp tip morphology, but the calcium burden is around at 8% of calcification. So next slide. So this is today's case.
Okay, so this is the RCA CTO. So as everybody can see, anyways, the CTO length is relatively larger, greater than 30%. So I think a very time-limited session. So for the better discussion, today is a bilateral injection angiogram I will show. So this is our room is a biplan, and in the both femoral approach, and also both 7 branch guiding catheter was used. Aorta is slightly deviated, so it's a little bit struggle to engage the two angiogram. Can you see today's angiogram?
Yes.
Yeah. Okay. So this is the angiogram. So because of the revascularization of LAD and circumflex, so a little bit improved collateral flow was observed. Okay, this is some summary of today's case.
Okay. At this time, I want to take panel's opinion. Any opinion?
Kim, Dr. Kim, I'm
Okay,
John.
John.
Yeah.
Okay, good afternoon.
Yeah, thank you for your nice case. I think I try to integrate the approach firstly because it's a long region. However, proximal cap calcification is not severe than the distal cap. So I will try to anterior approach first, and then after LAD PCI, the collateral connection is better than later PCI. So if we fail the anterior approach, then we can extend to the retrograde approach via septal collateral.
Okay, good.
Dr. BK Kim, this is Jong-Young Lee.
Okay,
So,
hi, Jong-Young.
Yeah. So this patient showed the relatively decreased renal function. So minimizing contrast is also really important for this situation.
Right. Yeah, right.
So in terms of the contrast amount, maybe I use the bilateral approach. Firstly, distal septal and insertion of microcatheter. Just to use the small amount of contrast can identify the anterior wide position. So even in the use of the anterior approach, I must prepare the retrograde microcatheter.
Right. Exactly good.
Yes. So, Dr. Kim, I'm Shozo Ishihara speaking.
Shozo, hi.
Yes,
Yeah.
good afternoon. So, I'm totally agree with Dr. Lee. So this is kidney function, so lower patient, and also there is a big bifurcation. So it is a very good indication for the retrograde approach. But
Right.
of course, this is a long region, so that antegrade preparation is also important. So that
Right.
for my opinion, first of all, I start from antegrade, and if the wire is easily crossed at that time, it's okay. But if it takes a little bit time or it is difficult, at that quickly switch to retrograde. It's my opinion.
Okay.
Yeah, Dr. Byeong-Keuk Kim, I'm Sang Kim. Yeah.
Okay.
Your angiograph frame is too low, so I cannot confirm the LAD stand position is medial LAD or proximal. We cannot definitely see the stand position in LAD because the LAD stand, there's some possibility of the LAD stand, some comprise for the septal branch for collaterals, and that makes some difficulty for retrograde wiring. Yeah.
So Sang-won, so
Yeah.
you must be familiar of this low count of the frame, okay, for your hands.
Yeah, okay,
right? So
okay.
in the monitoring, so we can see, right?
Yeah, absolutely.
So the second and third septal branch is preserved. Right?
yeah,
The
okay,
stand is
understand.
a little bit proximal portion.
Okay, understand. Yeah.
Okay, Dr. Kim. Dr. Kim, I
Yep.
think you already done the selective angiogram.
Okay, so previously Jong-Young and Ishihara told me. So anyway, the problem is some limitation of the contrast volume. So the initially I think there was no definite single collateral collateral from the septal to RCA. So and also we had some time, but the broadcasting is very limited. So I first. 그냥 돌리면 되나요? Next. So during this session, anyway, I prepared in the LAD and next one. So and also I searching of the septal collateral flow first. Next one. The last one was not so good. Next one. In the middle portion of a septal branch. Next one. Next. Next one. Yeah, so this is the septal surfing. Yes. This branch
cross
would
the
be
stent?
good.
Stent cross? No?
Oh, no. Just distal.
Just distal.
Yeah. Next one. And then I use this channel. Next one. This is the SO03. Yeah, so and this direction was not so good, so the removed again, and then the forward again. Next one. Yes, and then after that, the wire easily go past the PDPL branch. Yeah, so this is the RAO and LAO image. Also, you can see we clearly see the distal landmark. So this is kind of a mark stent approach. So next one, after advancement of the retrograde catheter, I used the Corsair Pro, yeah, both Corsair Pro. And then next one. Okay, so now at the retrograde micro catheter, just near of the PDPL bifurcation, and then as you can see, is RCA guiding system was not so good. But the RB branch is very promising. So for the preparation of antegrade, I used the RB branch for the anchoring. Next one, and then gonna start to the antegrade preparation. So Dr. Okamura, which wire would be good for the antegrade wire?
Yeah, I think that's a relatively the long region, so that's why I wanted to use the UB3 or Gradius, not the Conquest or Gaia. Yeah, maybe I want to keep the wire inside the vessel.
Okay.
Why Gladius, please? Gladius, the benefit of Gladius in this situation?
Yes, because the Gradius is easy to advance, but the UB3 wire or the Miracle Nail is much safer. But if difficult, I will switch to the Gradius, not to the Gaia. My feeling, Gaia is risky compared to the Gradius. So which wire do you select?
So I learned a lot from Dr. Okamura, so I exactly same thinking. So I now use this is the UB3, so I'm gonna start the antegrade preparation a little bit. And then from the CT scan, so in proximal portion, the scanty of the calcification, so anyway, I will advance with this UV3. Feeling was not so bad, so I want to advance a little bit more. This is aerial caudal view. Okay. So in this portion, I feel here a little resistance. So what do you think the change into the Gaia next series? Or more advanced again with this wire?
If I were you, the UB3 tip morphology and action was not good, so I think we have already distal wire as a landmark, so even Gaia next second or third is okay. I believe.
Okay.
Yeah.
Okay. So I want to change the Gaia series.
Yeah, okay, yes. Yeah, sometimes the UV3 cannot get the intraprocular something, some tissue. So sometimes the Gaia can get some tissue inside the CTO body. Yeah, I agree. Yeah, because the CTO course is very nice. So maybe inside the vessel. So that's why the Gaia will work in this situation. So are there any comments from Dr. Ishihara?
Yes, I totally agree with Dr. Kim and Dr. Okamura. I start from UB3, but after that, if the lesion length is so that wire is advanced, and so it is nearly to the distal exit, at that time I choose the Gaia to puncture the distal cap. So with the information of the retrograde microcatheter injection. But in this point we can see the little bit more long length, so that before the Gaia I will choose the Gladius. So to avoid the perforation.
Yeah, so maybe in Japan Gladius Gaia, that is very difficult to say, but controversial. So some doctors say Gradius, some doctors say Gaia. So but to keep inside the vessel is Gradius is better. Yeah, but if you can change the route or something, the Gaia will be better. So it depends on the feeling. It's difficult to definite.
If the operator has a very strong confidence for doing the tip detection ADR for the next step, you can choose Gradius. And if you want to track not sub-implant tracking, probably the operator choose Gaia.
Yes, that is the answer. So yes. Yeah, Dr. Hirohata clearly mentioned. So yes. So inside the vessel, Gradius and do the IVUS and tip detection intra or ADR. But if we wanted to keep the intra-plug tracking, not using the IVUS guided wiring, so doctors will choose the Gaia, like Dr. Kim.
Dr. Kim, Dr. Kim,
Okay.
how is feeling?
Okay, so also I think it's very little resistance. So
resistance.
before the advancing the some bended portion, so I feel some resistance. However, in now it's okay. So maybe
Almost
near the
Yes.
The wire is the Gaia next third.
gas. Next to
next 3, third,
Dr. Okamura,
next to
2.
yeah.
in this situation, anti-thread wire stop and retrograde wiring, or just anti-thread go, which one is your preference? More anti-thread wire advance, or just the digital retrograde wiring to the approach? Which one is your preference? Because usually anti-thread Gaia wire may make the dissection or subintimal space. So
Why don't you do that? Retrograde chip injection from retrograde microcatheter right now. Probably you can check the wire position from the antegrade.
So if difficult, I think it's better to go to the retrograde wiring and do the reverse cut.
Okay.
So one try of the anti-thread wiring, but the difficult maybe you are thinking about the next, maybe the retrograde wiring. But the Dr. Kim may be feeling the good. Feeling, as he will do it.
Okay, so let's follow the recommendation. Anyway, this is better to check the even despite of the total coronary angiogram. So I check this angiogram. Position was good, but I don't like the aerial caudal. Aerial 줄까요? Yeah.
First man.
Right. Yeah. First man. Yeah.
I think at this time we start to reverse cut.
Okay.
So now you can.
Okay, what do you think? So already I did retrograde wiring. But sometimes, usually for the antegrade wiring, sometimes just use the parallel wiring. So what do you think the retrograde approach and with for the reverse cut would be good, or antegrade parallel wiring again?
I think you already made a pursuit in the anterior approach. So I think it's time to combat retrograde wiring, and the reverse cut will be better for time saving.
Okay.
I think most panelists want reverse cut at this time.
Okay.
Please start.
even doing antegrade wiring or also parallel wire. But so we have the retrograde approach just now, so that the first retrograde wire should be advanced, so that it is a good information for antegrade wiring. So reroute again. Yes.
Yeah.
This retrograde chip injection gave us some information for the distal cap of the CTO.
Yeah.
So distal CTO seemed to be a little bit more proximal than expected.
Right. So actually, previous injections, I only see the PD and PR. However, so we can see some portion of the distal LAD.
So I think this is a very good candidate for the retrograde approach.
Good.
Yeah, I also advance the retrograde guide wire into the proximal part, then do the reverse cut, or I will do the kissing wiring. With just simply advance the antegrade wire to kiss the retrograde wire to the distal part.
Which wire? Retrograde wire?
Shion black.
Shion black.
Yeah.
In my opinion,
What do you think?
Yeah, so more proximal. Yeah, exit.
Right. Yeah. Gap is very different, right?
again.
Yes.
So the previously I felt some resistant point is some calcification point. After that, the wires go out in the first lumen portion. 컵을 주세요. Save. So I moved some wire position again over the antegrade wire.
Yes.
Dr. Okamura, in this situation, IVUS guided tip detection method is not available? Is it also available?
In this situation,
Yeah.
so yes, so maybe it's better to do the just a retrograde or reverse cut or something. Because if there is a short tip IVUS, IVUS guided tip detection method is available in this situation. But no short tip IVUS, so I recommend to do the retrograde, just simple reverse cut or kissing wiring. Yes. Yeah, nicely advanced the retrograde access to the proximal part. So maybe some bending is there. So that's why it's better to advance the retrograde wire, more stiffer retrograde wire to proximal part. But the antegrade try to do the kissing wiring difficult, are going to retrograde wire change to the more stiffer wire.
Right. Okay, a little bit resistance here. What do you think the most efficient wire for the retrograde?
I think in this situation, controllable wire such as Gaia series is okay.
Gaia series?
Yes, I agree. Dr. Lee. Yes. So retrograde.
How are you?
Control wire is better.
what do you think the gap of the both wires is enough to perform the reverse cut, or a little bit more advanced of the, or some narrowing the two wires distance?
Yeah, I think that's more advancement of retrograde guide wire because antegrade retrograde guide wire there is some distance. So just one kissing point, but I think better to parallel, kissed at the proximal part. So maybe I will advance the retrograde guide wire like a Gaia to more kiss the antegrade wire proximal part.
Next one. Yep. I will change.
I agree with Dr. Okamura's opinion because
Next one.
efficient reverse cut, we moved to the kissing part more proximally. It's okay. Yeah.
So now I change the wire shown black into the next one in the retrograde wire. So I a little bit more advanced this retrograde wire.
Okay. So maybe you passed. But some distance. Yeah, so maybe wire is already twisted, so that's why you passed.
Okay. Yes. A little bit. To minimize the size of the force lumen, sometimes just advancing of the antegrade microcatheter, and then I want to wire into that portion. However, so not always not easy. Anyway, we need some dilation of this portion.
Yes, I think it's almost enough. Much longer is much better, but the
almost reach.
Okay.
Yeah,
but
almost same lumen.
Same lumen. Okay, but I feel some resistance here of the retrograde.
Why don't you dilate that with the kind of crossing point for the minimum
Okay. Yes.
dilation
I will
from
do, I will
antegrade?
do, I will do.
Now,
2.0. 띠벌로.
now this time is antegrade ballooning.
오케이, 벌룬. 12. 띠벌룬. 6개. Just for saving the balloon, so I first use this relay balloon again. 다시 줘. Okamura, Dr. Okamura?
Yes.
Yeah, so now the number of CTO PCI in Japan, the number is now slightly decreased, or increased. Not easy to find.
Yeah,
Good
so
CTO.
maybe, yeah, I think that's like a plateau. So no decrease, no increase. Just my feeling is same. How do you think, Dr. Ishihara?
Right, yeah. So in Japan, so some doctors know, so we should perform the physiological test, FFR or scintigraphy, to detect the indication of the existence of ischemia or not. So normal PCI is slightly decreasing, but CTO is, I think, plateau.
Yes, yeah, I think my feelings. Yeah, so maybe it's better to check it. But yeah, how about in Korea?
Okay. So many problems now anyway, and also many young generations want to do the CTO PCI. The number a little bit decreased. What do you think, people?
CTO lesion is increasing, but however, we prefer to medical treatment nowadays. Yeah. And difference between the
Past from antegrade. Yes, yes. The route was changed. Okay, yeah, very nice. Just in time.
Time saving. I just put some angiogram. Okay. Antegrade wire crossed.
So you directed the proximal path. So maybe the guide wire course is changed after
Right.
dilatation?
Change it, right. You are right. 쓸 거야. 콜 세워주세요.
Dr. Kim,
Yep.
we have only 2 minutes.
Okay, okay.
Please summarize today's case.
Okay.
Yeah.
So Dr. Okamura mentioned, anyways, some modification of the CTO portion. So the antegrade wire repositioning very effectively gained some true lumen. So anyway, this is also is importance of the some CTO path. Previous mentioned is from the CT scans. We definitely had some middle portion of the CTO that would be the struggling point. So the reason why I should choose some hybrid method in the antegrade and retrograde, and then also every doctors recommended some reduced contrast volume and also sometimes retrograde system injection or retrograde PCI is more better. So to reduce the angiogram. So I can reconfirm after crossing the corsair and then check the IVUS, the wire is a real true portion or not, and then I put the post stent. I put some stent and also the IVUS guided the CTO PCIs ongoing. Okay. Thank you, Dr. Okamura and Dr. Lee.
Yeah,
Thank you.
thank you. Yeah, nice
Thank you
observation.
for nice presentation. Okay.
Okay. So we'll move to the feature lecture. So the first topic is Dr. Takuma Tsuda from the Nagoya Exaikai Hospital, Japan. His lecture title is It's a Bird, It's a Plane, It's a TD-ADR. So.
Thank you, Chairman. I'm very honored to be here, the Complex PCI 2024. So my lecture is about the TD-ADR. So, but I'm now I've been nervous because the Dr. Okamura is real the first opinion leader in this field. So that what is the detection method? So unlike the conventional 3D guide wiring, so or conventional IVUS-based wiring, the tip detection method is used for the 3D wiring according to IVUS guidance in real time. So we have to care about shaft location and tip detection and control wire rotation. So this is a real world of the tip detection. So the second operator is controlling the IVUS console, a gently manner. He controls the IVUS console, the forward and backward, a little bit gently manner, and suggest to the first operator to turn the direction of the guide wire chip. So, as you know, this bench model clearly identified that, demonstrates that the utility and the efficacy of the tip detection method. Actually, this green target is only the 0.6 millimeter. It's real the insert needle inside the CTO. However, by using the tip detection, so guide wire of the undergrad wire was well controlled to chip in the retrograde insert needle like this. So the tip detection is also used for the intra-plug tracking. So the IVUS clearly demonstrate that the target is around 5 o'clock in this case. So the chip was controlled a little bit more clockwise rotate, and finally get into the target inside the plug like this. So the tip detection is also applied for the ADR. It's called to the tip detection ADR. So this is a LED CTO without the interventional collateral flow. So at first of all, I performed the road operator for the LED2 scepter to passing the IVUS caster. So IVUS clearly showed that the LED CTO is 10 o'clock. So gentle manipulation was performed from the anti-grade wire. Maybe I'll be more rotate clockwise. So the chip of the guide wire is now looking for the 10 o'clock. I'll be more clockwise and push, and finally get into the CTO entry like this. So, but unfortunately, the XTR could not pass get the distal true lumen. So the Go IVUS for identify the guide wire position and the true lumen. So IVUS clearly identified that the true lumen is around 10 o'clock and very shrinked. So it's time to the TD-ADR. So guide wire was gently manipulated. So in the IVUS, real-time IVUS clearly show that the target is around 10 o'clock, the 12 o'clock. So, but very compressed with hematoma or dissection, so that it's like a D shape. So, but gently manner, the guide wire was counterclockwise rotate. Now the 7 o'clock. Now a little bit more 6 o'clock. So target is 6 o'clock. It's okay. And push gently. So, and finally get into the distal true lumen like this. Like this. So the blackout sign is also important to check the microcaster position to de-escalate the soft wire. And finally, we can recognize this CTO like this. So another case, this is a very interesting case, the circumflex CTO case. So I performed twice TD-ADR in one CTO in this case. So I performed the undergrad wire escalation with XTR, but unfortunately the XTR moved into the subintimal space. So I was clearly identified that the true lumen at 9 o'clock or 10 o'clock around here. So I tried to perform the chip detection intra-plug tracking from the entry site, but it also failed. So I performed the TD-ADR at the bifurcation site, but it also failed. So after failing this procedure try, I performed the TD-ADR at the far distal point. So finally, I could pass the anti-red guide wire into the true lumen. So that, but I failed to get the OM branch by a reverse wire technique. So I performed the intermediate guide wire insertion for the OM branch and for the tip detection for the OM branch. So I was clearly identified that the distal target is 6 o'clock, but very, very narrowing. So the guide wire chip is now 6 or 7 o'clock. So target is a little more counterclockwise, so that the guide wire gently control clockwise and pierce the true lumen like this. After checking the blackout sign, the shown blue could advance the distal true lumen like this. And after that, reverse wire technique was performed to protect the pair branch. Finally, we rekindled this CTO with the decay crash. So this case is very interesting. So, but first of all, the TD-ADR was failed at the bifurcation points. So I tried more distal site to perform the TD-ADR. And after that, because the reverse wire technique was also failed to protect the OM branch, so I performed the TD-ADR again for the OM branch like this, and performed the reverse wire technique from the OM branch. So in my conclusion, the tip detection method is feasible technique and brings strong performance in anti-red approach. On the other hand, the larger hematoma or dissection could be expanded far distal. So we have to care about the case selection. So we consider the retrograde approach when the collateral channel is interventional or the CTO exit have the very, very large side branch. Thank you.
Thank you. Okay, the last topic is Dr. Okamura. The title is IVUS guided wiring in CTO PCI, please.
Okay, so I also show you the case-based learning. So yeah, Dr. Tsuda already mentioned that IVUS fluoro-guided 3D wiring difficult going to the intra-product tracking tip detection method and difficult tip detection ADR. So that is the strategy using the IVUS tip detection method. So the case is 90 years old, but she had unstable angina. He administered into another hospital. So the LMT was, there was a severe stenosis, and also there was a severe stenosis at LAD, and the CTO region was there. So the patient was transferred to a hospital to receive the intervention. So we did a rotation, LMT to LAD, under the IVUS, under the IABP support, we dilated it and put the stent, and we recanalized, dilated LMT to LAD region, like that. So in 2 weeks, we did a L6 intervention, CTO region. So CTO region was also very calcified at the proximal site, entry site, and also there were no interventional collaterals from the RCA or the another branches. So we performed the IVUS guided wiring. So LCX region was like that, very severe calcified. So we couldn't attend the conquest or the guide wire, Gaia wire to the intraplaque route because of the calcification. So we intentionally advanced the maybe the Gaia third wire to the subintimal space like that using the tip detection method. Then we changed, advanced the corsair and changed the guide wire to the Gradius and do the knuckle wiring because there was a very huge calcified regions is there. So after that, we did a tip detection method, TD-ADR, before the bifurcation. Bifurcation was there. So that's why before the bifurcation, we did a tip detection method and penetrate the subintimal space to lumen like that. Then we advanced the microcatheter to see for checking the black sign like that. Then we changed the guide wire into the soft wire. The guide wire was advanced into the distal part. We did a conquest ST wire to penetrate. They changed the wire to the soft wire. Then we put the two stent and we recanalize like that. So we already performed around the 70 TD-ADR cases, and we succeeded in the 68 cases. So re-entry wire was the Gaia side in one case, a Conquest 20 gram in 3 cases, and Conquest ST wire in 64 cases. So I will show you some recommendation how to do it. So recommendable long axis puncture site is just beyond the CTO exit before the first major branch. Then if the exit is located at the bifurcation region, it's better to re-entry from the CTO body to preserve the branch. And also this is a short axis puncture site, recommendable site. So the two lumen is a very nice, healthy one. But if you try to re-entry it, sometimes the guide wire is deflected, and also a two lumen is deflected. Maybe 70% it is a little bit difficult to re-enter. So I just recommend this 6 short axis puncture site. Like this, try to use the IVUS catheter to keep the penetration force for the ST wire, re-entry wire from the front side, and also the lateral side. This is easy to get the support from the vessel, and also the back side. Maybe the Dr. Tsuda last case is a backside puncture. So because the puncture from the lateral or backside, where the two lumen is less deflected, due to the fixing force to the medial, like that. So we support from the blood vessel in closer area, like that. So another, from the opposite side, there are another 3 approach sites. So that's why the 6 puncture site we are recommending. So we already did this tip detection method, interplug tracking from the 2019. So in this 100 cases in 1 year, so the antegrade guide wire escalation success rate is 64%, but the tip detection interplug tracking is 70%, and retrograde 12%. But we started the tip detection ADR around 2020. So just now the tip detection antegrade guide wire escalation is 65%, but the tip detection method, interplug tracking, and the tip detection ADR is 25%. Maybe the percentage of the tip detection intraplug and the ADR is 50-50. And the retrograde is just now the 8%. So in conclusion, tip detection method enables real-time accurate guide wire navigation to the target, not only in the intraplug tracking, but also in ADR. However, just now, device work of the IVUS, especially IVUS, is a problem outside of Japan and Hong Kong and Japan. So we are just pushing the IVUS companies to export or make the short tip pullback IVUS for the CTO intervention. So thank you for your attention.
Any question or comment?
I have a simple question to Dr. Okamura. If TD-ADR, if there is some segment of pulse lumen, and then you have so much case, and then did you have any experience of aneurysmal change after stent implantation during you can check the follow-up angio, and then possibly in some subintimal pathway, and then some aneurysmal change after stent implantation in the pulse lumen.
So hematoma is there, but after put the stent like a reverse cut, so the subintimal space is already complex. So that's why maybe it's okay. But the major problem is the distal part. If there is a subintimal space is there, so I put the stent, so the distal part, there is a subintimal space will be still there or growing up. So that's why in that case, I leave the subintimal wire there, and I advance the microcatheter during the stent implantation. After stent implantation, I did a suction from the distal part to correct the hematoma, reduce the subintimal space, then pull out it. So that is my just strategy.
Yeah, I mean, not acute complication, but follow-up angiography, we can see some after reverse cut technique, and then I experienced some aneurysmal change after subintimal tracking. So TD-ADR also similar mechanism because there is some tracking of a subintimal pathway. So I think it also same scenario of a stent path in the subintimal space.
Yes, yeah. The same scenario. So, so maybe I'm just worried about the length of the subintimal space. So, yeah, retrograde approach also makes the subintimal space, but the IVUS guided wiring, including tip direction, especially tip direction ADR, sometimes a longer hematoma space. So that's why I'm just worrying about. So that's why I will do the stroke technique to correct the distal hematoma if needed.
Okay, because time limitation, this time to closure. Thank you for operator, panelist, and speaker and audience. Thank you.